Hello!
Okay,
I think we're going.
we should be good.
All right.
So before we get started, we're just going to acknowledge that we are live on Facebook and Instagram, so we've got multiple devices open at the same time. And we also know that the PowerPoint is backwards. So this pops up every single time where people say, hey, your PowerPoint's backwards. And I'm like, I know. If you want a copy of the PowerPoint, shoot us a DM.
Yep, we'll get it sent over to you.
Yeah,
So.
absolutely. So, hey everyone, I'm so glad that you guys are starting to pop on and join us. I'm Dr. Geyer.
And I'm Marion Mitchell.
So I'm an integrative physician. We do a lot of chronic complex disease for anybody that does not know. And we do, well, a little bit of everything, but IBS is a really special one for us. I think autoimmune and IBS were a couple of our favorites.
Yeah.
And that's because those are two things that we see the most of. So IBS is probably the most common concern
Definitely.
that pops in for us.
I would say that I get several a year who are just like, I don't know what to do. And like all the tests are normal, but I'm in pain.
Yeah.
And it's very frustrating, and it's because the whole picture isn't being looked at.
Mhm.
And so that's what we're going to dive into today.
Yep.
Very excited.
And I would say probably 80% of my patients have some form of IBS or actually have IBD. If you have IBD, that's separate, but it was misdiagnosed as IBS. So we're going to give you lots of tools today, go through lots of information. Really, we could go into every single topic and do just a webinar on that or a
Yes.
lecture on that. So we fully acknowledge that, but we're trying to give you as much information as possible in a short amount of time so that you have the tools to move forward, feel a little bit more empowered about your symptoms, where to go with testing, where to start, what can you do now. Okay?
Exactly. All
Awesome.
right. So the title is IBS. It is not all in your head. Let's see which button it is. There we go. All right. Our disclaimer. Okay, because we have to say this. This presentation is for educational and informational purposes only and should not be construed as medical advice for any individual. We encourage you to speak with your physician or schedule an appointment with our office for appropriate medical evaluation, testing, and treatment. All right. And this is us again. Hello. All right. So first up, we wanted to dive into what our patients are told the most.
And there were a lot. These were common ones between the two of us because we did a little bit of a comparison, and I brought it with you, and she's like, I've never heard that. And I'm like, okay, we won't use that one. So it's all in your head is the number one thing I see. People will come in and they'll say, they put me on an antidepressant, and I'm so over this one. Like, antidepressants may help some of the GI symptoms, and that's a whole other, topic that we could delve into later. But it's not in your head. That's not quite how that works, although the gut is the second brain, and we'll talk about that. So yeah, here's some antidepressants, anti-anxiety meds, very, very common. When we don't know the answer, that's what
the
conventional
go-to.
medicine throws on it.
Yeah.
It runs in your family, so there's nothing you can do. So I hear this all the time with people in my office, and they're like, but my mom has it, so I know I have a spastic colon too. That's what my mom called it, was a spastic colon. And I was like, okay. So that's not the case. Like the things that could be risk factors for it, like there are some genetics we're going to talk about and epigenetics. But what runs in families are habits, a lot of
Dietary preferences.
patterning, and you're also exposed to similar bacteria, which people aren't talking about the bacteria component of it.
Or lack thereof. If you have somebody if you have a mom who's like overly sanitizing and uses those really harsh chemicals that actually can disrupt the microbiome.
So we'll go through a lot of those things that contribute as we kind of tease apart, because it's often multifactorial for IBS and not just the slam dunk like I would really like it to be for everyone.
Yeah. All right. Just eat yogurt and you'll be fine. Again, that goes back to bacteria, probiotics. Like you just need some probiotics and reset things and it'll be fine.
Totally fine.
Totally
just
fine.
Have some probiotics.
Or take a
Absolutely.
probiotic for the supplement lovers. Just take one and that'll fix it in a couple months.
Anyone you pick up over the counter is totally fine. So I hear that one quite a bit. It's like, just pick one up at the grocery store. It doesn't matter if it's refrigerated. Like, it's a live organism. Of course it matters. So.
And you definitely don't need to change the way that you eat. There's nothing you can do.
Yeah.
That one's my favorite.
It's unfortunate. So that we started with this series because we really wanted to empower people, and we were like, how can we better empower people? And by creating these talks and these webinars, that's our goal. So my goal is for people to stop being disempowered, which a lot of the system is just kind of set up that way, and I function in that system, so I totally get it. It's the dynamic of it, but that, like, you don't need to do anything because there's nothing that you can do that's going to help. That is our goal, is for that to go away and you to get some good empowerment.
There's a lot that you can do. There's a lot in your control, and so we're excited to share that with you.
Okay, so the many potential root causes of IBS, and I'm not touching on all of them, but I'm going to read through this list because this is super important. So at the top there's food sensitivities, and I'll break those down a little bit. We're going to go through most of them individually. Constipation, H. pylori, SIBO and SIFO, which we actually did an entire video series on YouTube, so we're not going to go into the depth that I really think that a lot of these deserve, but we are going to touch on it and see if you need to get in the ballpark, and then send you over to those videos so you can get some more information on them. Gallbladder issues. This is near and dear to my heart. I'm seeing way too many patients who have had their gallbladders taken out, who did not need to have them taken out. And we'll talk about that in that section. And then removal, so issues after it was removed, when the IBS didn't go away or the acute abdominal pain didn't go away. And then there's things like post-cholecystectomy syndrome, which we'll talk about in that section, where you actually have all these other issues as a result of your gallbladder being taken out, because it turns out that useless organ isn't useless, it's super important. Now, I'm not saying some people really need to have theirs out, and that is absolutely the truth, but we'll talk about that there. Dysbiosis is kind of a funky, like, it's a well-recognized term, which is why I use it, but it doesn't really do us the credit, or do this topic the credit that it really should be, because dysbiosis just means that the gut microbiome, so the bacteria, the viruses, which we aren't talking about today, but that's a whole other gamut, the beneficial bacteria, the commensal that kind of hang out, some of them are really important for us outside of our traditional beneficials that we know about. And some of those yeast and actually fungi, which we're going to talk about fungi outside of what, just the candida component in that section. Pancreatic insufficiency, we'll talk about enzymes. So again, when I talk about gallbladder, I'm going to talk about the pancreas and creating digestive enzymes and what that looks like. I've seen that misdiagnosed quite a bit, but I'm also excited that people are starting to recognize it. So not everybody makes enough enzymes to break down their food in a really good way.
Or they lose them over time.
Yeah, of course, yeah. Antibiotic overuse. We try and drive that home pretty much every single lecture.
Yeah,
because
it contributes to so many health problems.
So many pieces.
Yeah.
Scar tissue is one that I don't hear people talking about, and I really wanted to bring this up of the things that aren't well recognized, is scar tissue after surgical procedures. I'll see it after any type of surgical procedure in the abdomen, and endometriosis, since I've had patients that have lost sections of their colon when their IBS was blown off, and they said, oh, you're just constipated, oh, it's just IBS, oh, it turns out we have to take, this length of your colon out now because it's necrotic and it was strangled by endometrial tissue. So I want to make sure that you aren't just like, okay, there's all these things that are a little bit more ambiguous, and then there's some very specific things like this that get missed, and those can be scary. And then medications. So people don't necessarily think about the side effect profile of medications. We didn't dedicate a slide to this, but I want you to keep in mind anytime you start a medication that they all have common side effects. Those are expected. And then if you have certain genetic variants, I do a lot of genetic testing where we can see how you metabolize medications. They might have more of an effect. But constipation is, fairly common. Constipation, diarrhea, abdominal pain, nausea are very common ones outside of those rashes that we tend to think of.
Yeah. Well, I just think about pain meds. And how those stop people up so bad for really long periods of time.
Okay.
All right. Let's see the picture. I don't know if you guys can see that.
I'll give you a little bit of an idea. So what we think this looks like versus what it actually looks like, this is one of my favorite analogies more recently is, so in my community, we often talk about this is an onion, which you can't probably see very well, but somebody's peeling back the layers of an onion, and we say, okay, well, your root causes or the things that are causing these things, you go layer by layer. What I found working in chronic complex disease and doing so much of it is that it's a lot less like layers and a lot more like this jumble of necklaces over here where we're teasing it apart. So I would definitely say the way that I practiced 10 years ago or more is different than it is now, where I was like trying to peel back one layer at a time and say, okay, let's start with your large intestine, let's start with your small intestine. I'm still systematic about it, but it ends up being teasing it apart and being really systematic about it and not ignoring things that may also be a piece of this. So like I said, it's rarely, I do have those patients where I'm like, your IBS, food sensitivities, we take them out, slam dunk, all gone, and I'm like, this is fantastic. Like,
Yeah.
I wish it was all like this, but the longer that we're sick, the more likely it is that there's multiple, underlying conditions that are playing into this, and we kind of have to tease those apart together. And I don't know that you'll have the tools to tease those apart on your own, but at least you'll be aware of them after this. Okay. So how we approach it, and again, we've got multiple tech. We have a couple computers and phones going on right now, so I don't know what view you're looking at. I realize it is flipped. Again, I'll acknowledge that. But over here is a diagram of your gastrointestinal system. And a lot of people think my stomach, which to most people is their entire abdomen, when I talk to them, they're like, oh, but my stomach this, or my stomach this, or my stomach this, and it's all kind of there. But that's not really the way that this works. So how we approach it, I call it the top to bottom, inside out approach. And we start with a really important, like, two things. One, getting very systematic about it, and two, putting it on a timeline. So I start everything in my intake with a timeline. I say, tell me about how this started, how it changed over time, and how it is now, including any workup that you've had, treatments, what's worked, what's not. Let's start at the beginning. So we do this for every single concern, and you can do this ahead of time and bring it into your functional medicine doc, your integrative medicine doc. It's a little bit harder to bring it into a conventional doc that may have like 6 minutes with you and say, here's my timeline, and they're like, great, I'm not going to read that, right? Like, they don't necessarily have that time. Those are the constraints within the system that we function in with insurance. I put a video up earlier that we've chosen not to function in that system any longer, so that we could spend one-on-one time with patients and really get them better. But make that timeline. You can do it. I suggest you always make, we talked about this in the autoimmune, I think, that you make a binder of all of your tests, all of your labs, imaging, everything in there, and the important things, and make sure you have a timeline. So sometimes it's really messy and it's hard to make that timeline, but other times when you really sit there and think about it, you're like, wait a minute. I remember I was really sick, and I had this antibiotic, and then afterwards I just didn't feel right, and then I developed some indigestion and some reflux and some burning, and then it started waking me up at night, and then I was also constipated after the antibiotic. So, and then start to tease those out in that timeline. So you can make your own timeline, and that will help you. So our approach, timeline, thorough intake, top to bottom. And I'm going to talk about that, I think, the next slide. Yeah. Of how you can do your own top to bottom. We call it a review of systems. So each of your systems, but really going from the GI system and top to bottom. And then that multifaceted approach, we're going to talk about that later. All right. Okay. So top to bottoms, and let's talk anatomy. Now, people either glaze over at this point. I'm going to ask that you don't glaze over. Just really recommend
Bear with us.
Bear with me, because this is super important as we go through what is your anatomy. So you can figure out, is it really indigestion? Is it really your stomach? Or is it not your stomach and it's actually your small intestine? And for you to go forward with the right kind of testing, or maybe even additional testing, if you've already done SIBO testing and your SIBO has come back, we hear that a lot, or this or the other thing has helped but it hasn't gotten you there, we want to help you stratify that. So that's where this top to bottom approach is going to be really helpful. So over here, and again, if you want a copy of the PowerPoint, let us know, send us a direct message, and then later on we'll put the entire webinar on YouTube for you to view, although it's a little bit hard without the actual PowerPoint, so let us know. So over here, most people don't think of digestion actually starting in their mouth, but think you smell something wonderful, you're already salivating, like let's say something's been cooking for a long time, you're already salivating. So your body's already getting ready to break that down. It's already pumping those enzymes into your mouth, right? Your mouth is watering, that's the point of that. And then your tongue is part of that. So think of your mouth. This is important later because we're going to link those bacteria in your mouth to your esophagus, to your stomach, and what that means is they transition. So you chew it up, you need to chew your food, very important. Swallow it, it goes down your esophagus. There's a little door at the bottom of your esophagus we call the lower esophageal sphincter. And so once it goes into your stomach, that expands. Stomach acid and other enzymes get pumped into your stomach. It'll cue that little door to close, which is super important if you have reflux and your door is not closing, so that sphincter is not closing. Sometimes that means that your stomach acid is not too high, it's actually too low, amongst other things that can cause that. So start to think of it that way as what's happening at each segment. This is your stomach here, so it's going to churn your food like the washing machine, if you were watching that, and break it apart with the stomach acid. And think about this, if you're on antacids, then you're not going to be breaking down your food properly. It's less likely that that sphincter is going to close. So hopefully there's some applicability there for some of you. Once it's done there, it's going to go into the small intestine here. Again, there's a sphincter on both sides. So I put them in here, esophagus, lower esophageal sphincter, stomach, pyloric sphincter at the bottom, and then it'll go into your small intestine. And once it's in your small intestine, the liver is going to make something called bile, which we're going to talk about, which will be stored in the gallbladder. And then that'll get pumped in and help you digest more. The pancreas is going to make enzymes. Those will get pumped in. They're going to help you digest more. Ultimately, the goal of all of this is for you to break things down, absorb them, build every single cell in your body that's made up of fats, proteins, and carbohydrates, all of your biochemical pathways, all of your neurotransmitters, all of your hormones. Everything's built off of what you eat. That's why we talk about what you eat in every single one of our webinars. So we'll talk about that later. And then the small intestine, getting everything basically ready to move out. And hopefully, at the end, you're pooping. And a lot of people aren't. So we'll talk about that here shortly as well. The other one, which I'm going to refer back to, is the ileocecal valve between the small intestine and the large intestine. Because if somebody does have an issue there, SIBO being a big one, or SIFO, where it's a small intestine issue, often we need to work on that valve. So we're going to talk about that later with things like maneuvers and chiropractic.
All right, so where are your symptoms? So we have the obvious ones, so we have upper GI, we're having burping, we're having nausea, and is it all the time or just after meals? Indigestion, heartburn and reflux, fullness in the stomach, so that's your, I don't know if you can see this, but when people say stomach, they think that us short people, but it's literally, if you put your hand under your stomach, it's that area, okay? Is that feeling very full? When then we have bloating, sharp pain right under the rib cage, and that might actually radiate up to your shoulder, and then constipation or diarrhea or both.
So some of these overlap, and I put them in blue for upper GI and lower GI. And that's because obviously, if you go back to that picture of your intestines, like all of this is a hodgepodge of your small intestines. It's looping around and looping around and looping around. And then your large intestine is here, it goes across, and then it goes down, right? And so your large intestine and your small intestine are going to overlap in these areas. And when you feel bloated, you feel bloated. So sometimes people will say, well, I think I have SIBO, small intestine bacterial overgrowth, or I think I have candida or something like that. And they're just like, they're saying, well, what are your symptoms? They're saying bloating. And I'm like, okay, tell me about your bloating, because that starts to help us tease that apart. Is it you wake up with a flat abdomen, and then throughout the day you start to feel more and more bloated, and by the end of the day you feel pregnant? Because that's usually a slam dunk for something like the small intestine bacterial overgrowth or small intestine fungal overgrowth. Versus people that are just always feel like they have trapped gas versus people that eat something and then get really gassy and then it gets better. We're looking at a food sensitivity there. So there is going to be some overlap between upper GI and lower GI, because really the upper GI, as we call it, is attached to the stomach and then the large intestine, but it's not really the upper half of your abdomen, it's all over, right? And the lower GI is actually coming here, here, and here, so there's a common misunderstanding about that, of your large intestine being lower GI, and actually you're feeling pressure right here. So super important.
And then other lower GI symptoms are flatulence and hemorrhoids. So,
I just want to say constipation and diarrhea was the other one that we didn't really touch on, because constipation and diarrhea can happen in either. You can have one, the other, or alternating. Obviously in IBS, one of the common things we hear a lot, and I mean every single day I have IBS patients in my office, every single day. And they're like, I'm tired of having to think about, when I leave the house, where's the closest bathroom? Is it going to be available? Especially now with COVID, they're like, okay, so it's not the same with, packing my mask and things like that. Like, I have to think about that bathroom scenario, as a lot of people were closing down their bathrooms and not making them available to the public. So this has been a huge issue. All right.
what about the ones that are not obvious? What about the ones that you don't feel in your stomach?
So this is super important, and that's why I threw up that first slide of the GI system and talking about, like, you see the mouth, and remember the nose, that mucosal membrane from here all the way down is all part of that system, right? So if you've ever thrown up and it's come out your nose, you're well aware that happens. It's like the worst. That's like that's my worst. I'm really not good at that. But nasal congestion is a really common symptom of, like, something happening in your gut that shouldn't be happening. And so that could be like a food sensitivity is a really common one, which we'll talk about. But nasal congestion, chronic sinus infections, people are like, oh, I go on antibiotics 20 times a year. And I'm like, what? No. And half the time, I'll give myself as an example because I can. It's not a HIPAA violation. I had a CT scan after a car accident, and they were like, oh, you're inflamed, you have an infection. They automatically gave me a Z-Pak, and I'm like, I have allergies. So, yeah, there's that. But chronic sinus infections do not necessarily mean that it's an infection per se. It's inflammation. The body creates mucus to protect itself. And that mucus does harbor, it makes this beautiful place, like a little swamp for bacteria and viruses and pollens. And here in the valley, fungal spores as well, like we'll see that as well, and mold, which we're going to touch on later, because mold is like one of the outliers that we don't necessarily think about with IBS, but can be really important. Headaches and migraines, huge, super important. We'll talk about that later. Ear infections, especially in kids. I mean, if it's swimmer's ear, fluid got in, bacteria bred, often Pseudomonas or a staph. If it's a middle ear infection or an inner ear infection, we're usually talking about, especially chronic, one is one thing. If they're getting it all the time, especially in kids, we're looking at food sensitivities. We're looking at what they are not able to tolerate. In adults, same thing, but a little bit different because our bone structure actually changes as we grow, which is why we don't really grow out of ear infections or food sensitivities either. We'll talk about that later. But our skulls do grow, and our eustachian tube from our ear into our throat goes from this to this. So we'll talk about that later. Dark circles under the eyes, we call these allergic shiners quite a bit. So people say, oh, that just runs in my family. I'm like, no, a dairy sensitivity runs in your family. I'm just using dairy. I don't know if it does, but it's a pretty common one. Thrush, so this is important. I have seen so many people with thrush that had no real understanding that thrush came from somewhere. Like, if you have a baby with thrush, you're looking at mom, right? Like, if they're breastfeeding, especially, that's what we're talking about. You're looking at mom and how did they get thrush. As an adult, where did that yeast come from? Down below. That's where that came from. So if you're just doing a short course of nystatin oral suspension, you're not going to get where you need to go, and you're probably going to have yeast for a very, very long time, which is going to turn into a lot of other things, because it creates this perfect, awful, environment for other things to grow. Chronic cough. I wanted to bring this up because I see allergies so much, and chronic cough. People will be like, you come in. I hear chronic cough, and I want to know, like, is this a lung issue? Is this an issue with GERD that has gone undetected? So like reflux can cause a chronic cough because of irritation. Or is this from that chronic postnasal drip? And if we're looking at postnasal drip, I'm trying to figure out what that postnasal drip is. And very rarely is it just environmental. So again, looking at what's happening there. Like, is there something abnormal in food sensitivities that are making you create mucus to protect yourself, and then you have that constant postnasal drip? Or is there something along those lines? Asthma, I'm not going to touch a whole lot on asthma right now because that's a whole big piece, but when we're looking at inflammatory reactions, we'll talk about, the atopic triads like asthma, eczema, abdominal pain is like the outlier, and allergies in kids, so we'll see those together, and we're usually looking at like foods or sensitivities that may be causing that. Eczema, dermatitis, psoriasis. So I am never, ever, ever looking at skin conditions without looking at the gut. And if somebody is, that's just a huge, that's a huge red flag for me. So often, especially in kids, eczema we know is food sensitivities. Psoriasis is a lot more complicated, so I am not going to make this super simplified because I don't feel like that's fair. But I do see a lot of food sensitivities in psoriasis that make it worse. And then we'll see, of course, like keratosis pilaris, the chicken skin, and a bunch of other skin conditions where there may be nutrients involved. There's usually food sensitivities involved. And then there may be some other stuff as well. Anxiety and depression. So I wish I could just spend like an hour on anxiety and depression and go back to the gut and talk about gut bacteria. Maybe we will, because we can do whatever we want. If you want to hear it,
if you want to hear about that, let us know.
We'll make it.
That sounds like fun. I like that topic.
We're basing a lot of these off of feedback that we got from either patients or online in social media, where they were like, "Can you cover this topic?" And I'm like, "Sure, okay." And then we always get carried when we're covering topics because we're like, "Yes, let's cover everything and tell you everything." But anxiety and depression, we know now that the brain is the second gut. We know that
the gut is the second brain.
Or the gut is the second brain, sorry. And that actually that the nerve conduction is so lightning quick between the gut and the brain. So you can instantaneously, you're changing, your neurotransmitters, and you are built to survive. We're all built to survive, right? Whether or not we've kind of built these civilization as we have. But talking about the gut and neurotransmitters and talking about gut bacteria is like a whole thing within itself. But anxiety and depression are things that people don't think about. That was my point of that. Fatigue, general inflammation, and we can go on and on, but I want to get to the top, each of the sections. Okay. Food allergies and sensitivities. So people have been asking me for a while, and you can't actually see over here, like what's the difference, symptoms, and testing. But people have been asking me for a while to explain the difference between food allergies and sensitivities, and I do this a lot in the office sitting across from a patient when I'm discussing this with them. So there are different immunoglobulins. There are different immune cells, right? And we're familiar with IgMs. When we have an acute infection, we'll check for IgMs, immunoglobulin M. When we've had a past infection, we have IgGs. And when we have IgEs, most people think of allergies. If they're severe, you need an EpiPen, right? If they're not so severe, then maybe you just have some runny nose and some itchy eyes, or if it's a little bit somewhere in between. Itchy throat, and then it can go from there to hives. People can have actually eosinophilic esophagitis, so they can get that reaction inside, which is a whole lot more complicated. We cover a little bit of that in autoimmune stuff. Which that PowerPoint's on YouTube if you're interested. Yep. So that's IgEs. Think, those reactions that lead up to an anaphylaxis, those true allergies is what we consider them here in the U.S. Outside of the U.S., things are different. But here, that's what we consider. So you're either going to get a blood test, or you're going to get a skin prick test or skin patch test. They're all a little bit different, and sometimes one is better than the other, and they do have different results so people can come up positive on one and not on the other. So allergists, that's what you're going to get in an allergist. I usually get people in who have said, I've already had allergy testing, I'm not allergic to anything, and I'm like, oh yeah, okay. So let's start with this conversation. Then there are IgGs and IgAs. Immunoglobulin A is happening at your mucosal membrane. So that's happening, at your nose, your mouth, your throat, right? So we talked about that. And IgGs are happening in the body. So these are more of a delayed sensitivity reaction.
So that's like, I know this was before I actually got into complex disease, and I had a friend who was off the charts reacted to dairy, but her reaction was 7 to 10 days later. So she was eating it and feeling fine, but then she was constantly feeling crappy, and then she would go on a cleanse and feel better, and then about a week after the cleanse she would start feeling really bad again, and then she ended up getting tested, and that's what it was, and it was a delayed reaction by a lot. That makes it difficult when your reaction is a week to a week and a half later.
You can get IgG testing through places like Sonora Quest and LabCorp. They are absolutely awful. If you come to me with them, I will say, let's rerun that, and let's do it through a specialty company. So that's super important. Their type of testing, their testing method, their equipment, all of those things make a difference. And I don't like archaic testing because our testing has advanced, and we should definitely be using it. If you had asked me 10 years ago, I probably would have said only run IgG. IgA doesn't give us that much information. It's because of the testing. It wasn't sensitive enough at that point. Now I never run one without the other, so I run IgG and IgA together. And I often run all three. I'm not going to go into different types of IgGs. There's a whole topic that we could talk about, the different subtypes of IgGs. We're not going to talk about that today. But I just want you to see the difference. So what people will often tell me clinically, so their symptoms is they have an IgA reaction, and it's pretty fast. I will use myself as an example again. I have soy milk, and I get super congested. Super, super, super congested. I really like it. I love a good soy latte. But I get super congested. That's my IgA reaction. It's right there. I drank it, my nasal turbinates, all of the cells swelled up, my body made mucus to protect itself, there it is. IgGs are different, so you absorb those foods and you're still having a reaction that's more of a systemic reaction. So this is when people will eat something and they get those symptoms you don't think about. Maybe you think about the IBS because it's obvious, but you don't think, hey, I also have migraines.
Or joint pain.
Or joint pain. Or any of these things. A patient told me a couple weeks ago, she goes, I just emptied out my my cupboard where I had all of my pharmaceuticals before I saw you, and I couldn't believe it took up my entire counter. All of the pharmaceuticals because of the fibromyalgia and the chronic fatigue and all of these ambiguous diagnoses that she's had, and her IBS and this, that, and the other thing, and all of them gone. So really for her, we did have mostly a slam dunk. I'm going to say this does not happen very often with food sensitivities where she has them and she develops joint pain, she doesn't, and it's all gone. So, all right. Okay. This is a big topic, and because we'd already done several YouTube videos on SIBO and CFO, I'm not going to go into a ton of depth about it. And I put H. pylori here. Now these are very different, and the reason that I put H. pylori here, and I don't have an example of the test on this slide, but if somebody comes in with reflux, indigestion, that feeling of fullness right here, we're often looking at H. pylori and trying to see if that's the cause of that. What I don't want is for something to be missed, like a small intestine, remember that upper GI overgrowth of either bacteria or fungus, so that SIBO or that CFO. So I'm usually running both of, all of that testing together and ruling it out as quickly as possible. And some of that, H. pylori testing is often covered by insurance. SIBO testing is not very often covered by insurance unless a GI does it. I very rarely trust the GI reports I get from them doing it in their offices, not because of them, but because their techs are doing it, and the readings are kind of all over the place, versus breath tests, and that's what I would recommend for SIBO, CFO, and H. pylori breath tests, so that's what I give to my patients. What we do have is a copy, and again, it's kind of bright in here with the projector, so you can't necessarily see it, but SIBO testing is not testing for SIFO, so I want to break those two out. So small intestine fungal overgrowth is not the same. SIBO patients, again, we cover that in our videos. They're going to have a lot of those upper GI. Oftentimes it's after food poisoning, and it could also be, so it's going to be an infection from either contamination with food, so they had that. They'll say, I had an antibiotic, and ever since then I've had this issue, so we'll hear that quite a bit. Or they had chronic constipation, and it backs up from the large intestine into the small intestine. And then it actually encompasses a lot of different bacteria in SIBO, some methane producing, some, well, one methane producing, to be honest, which is kind of hangs out in the gut. It doesn't create a lot of issues if there's a little bit. There's the hydrogen producing bacteria, and actually there's a little subset of hydrogen that we're not going to talk about today. That's a little bit more complicated. You'll have to go to the SIBO videos. They create gases. That's when people say, I wake up with a flat abdomen and I feel pregnant by the end of the day. And so this is what the testing looks like. A lot of people kind of poo-poo on tests and say, oh, treat empirically. I can't stand that approach. I have to be like really honest about it. I'm on my soapbox right now. People don't get better. People don't get better most of the time if you're treating empirically. I want to know what I'm treating. I want to retest. I want to make sure it's gone. And SIBO does go away, so I hear that a lot in the community. It goes away, and making sure that you treat those underlying causes so you don't get reinfected is super important, but I think other pieces are being missed. So it does go away. On this side, you can see the patient, it pops down from a negative to, I think they were at 142 positive on that result, so that's glaringly positive amount of gas. And down here, their methane went down to less than 2, and their hydrogen went down to 17. Now, it wasn't gone, but it was eventually will be cured, because we're still actually treating this patient. But she's a great example of a glaringly positive and the effects that good treatment can actually have on someone. All right, gallbladder. So your liver makes bile, your gallbladder holds it, a little storage vesicle. When you eat something with fat, it squirts it out. This is a really simplified version, obviously. Squirts it out, it goes through into your intestine, and it breaks it up. So think of a Dawn commercial, like when they used to squirt the Dawn into the sink full of dirty dishes or the sink full of dirty water, and it would like scatter. And that's what it shows over here. That's what your gallbladder, or at least your bile does, or your bile acids do, is they break up the fats. And so you need that to break up fats. Now, a couple things happen. Some people, their gallbladders don't work as well over time. So you may have had a test that says, oh, your gallbladder's at 25% function, and it should be above 35% function. And so those people may become symptomatic. The other piece that we see, of course, there are stones and there are sludge, and these can be reversed. I know you are probably already been told, or you knew somebody that was like, I was told that that wasn't reversible. I'm like, welcome to my world. Like, everything that's not reversible by other people, like, we reverse all the time.
All the time.
So, like, their diabetes, their hypertension, their, type 2 diabetes, all sorts of things. That's one of them. Gallbladder, I try and save it if I can, and some people can't. And most people come to me, or a lot of people come to me, and they already have their gallbladder out, and they're like, I don't know if it was ever needed to come out. And this is always really fun, because I get in their medical reports. I get in all records, and I go through them, and then I'm sifting through the hospital reports and the surgical reports, and I'm like, oh, this was a healthy gallbladder. I bet they never told them that, because people will be like, no, it was terribly diseased. It was just terrible. They told me it had to happen eventually, and I'm like, that's not what the report says. But that's okay. There's nothing you can do. Your gallbladder's gone. Bye. And what we need to know is now you can't squirt out a big bunch, or a big bolus is what we call it, of bile acids to break up that fat all at the same time. Instead, it drips like a leaky faucet, because your liver's still making bile, so it drips and drips and drips, and it causes some inflammation in your intestines, which we probably need to address before you end up with some kind of infection or inflammation. And then the other piece is we need you digesting fats, because your brain is made of fat, and every single cell in your body, the cell membrane is made of fat, and your nerves are wrapped in fat, so it's kind of important for like everything. And so there are some people, like, it's very common for people to gain weight after the gallbladders are out. Very hard to lose that weight. It's very common for depression and anxiety to happen afterwards. Remember, your brain is fat, and there's a lot of those complexities. So wait, IBS to develop afterwards or get worse afterwards, and they say, I just can't eat salad. I hear that a lot. Like, I can't eat salad now. It's okay. I never even liked salad. I'm like, that's not how that works. Like, you actually need to eat vegetables, so let's get you eating vegetables. And the good news is that we can supplement with bile acids. You can actually take a supplement of bile. So if you have your gallbladder out, or you know somebody who does, make sure they're taking a bile supplement every single time they eat food with fat in it, which is pretty much every meal for most people, and some of your fatty snacks. But that's the gallbladder. It's very, very, it's not given a lot of like credit. But again, my doctor said my gallbladder was diseased, myth or fact. It had to come out sooner or later. It doesn't serve a function. And once it's out, it's out. That's it. Nothing else to be done. Those are a lot of the things that we hear all the time in the office. So now you know that's not true. It served a function. Some people have to have it out. That's the reality, just like everything else. I'm very thankful for surgeons. I'm very thankful for a lot of those people that work within, you know, the hospital, and the jobs that I don't do. Okay. Pancreas. So I mentioned pancreas earlier. So gallbladder makes bile, and pancreas actually makes other enzymes. If you know what your pancreas is, a lot of people will know it because they know about insulin, and so they know about type 1 diabetes, or they know that their pancreas isn't working as well, or they're afraid it's going to burn out. But what they don't necessarily know is that it's making those enzymes for you to break things up. Enzymes like, you know, the ones in your mouth and the ones in your intestines, people will have an insufficiency, and this can actually happen just like idiopathically. We don't know why. It can come and go, which I've seen in patients where, you know, their amylase or their lipase levels dropped, and then they came back up. This is the importance of retesting. Anytime there's an abnormal lab, if you've ever had an abnormal lab, your doctor should, most of the time, unless it's like obvious and we're like, oh my gosh, we need to treat this now, should retest a lot of those types of things that would lead towards a diagnosis that we can't make a diagnosis off of. Some things we can, some things we should rerun and confirm before we make that diagnosis. And this happens to be one of them. Pancreatic insufficiency also happens with age. As we get older, we produce less enzymes. We have a lot harder time digesting, so in the elderly community, I'm often supplementing digestive enzymes because they just don't make enough. And that's why they're eating smaller meals, getting really full. They're more likely to burp. And then there's a few structural things that happen with us and whatnot. So with pancreatic insufficiency, the reason I also wanted to bring this up is because the symptoms overlap so many other things, and it is often overlooked. So weight loss, abdominal pain, flatulence, bloating, diarrhea, and nutrient and electrolyte deficiencies. So this is super important because I've seen this misdiagnosed with somebody who's like, oh, it's totally SIBO. And I'm like, well, if that's all they treat and they're a hammer, then everything's a nail. Like, I don't want to jump there. That might be the case, but it might not be the case as well. So one telltale sign that that's the issue is that the diarrhea is going to be really oily. So keep that in mind. If it's like really oily stool, that might be your issue. So that's how a physician will tease apart those symptoms and say, okay, do we really need to look at that? Or if we start to see nutrient deficiencies, especially like iron, B12,
what about sodium?
Electrolyte, yeah, your electrolytes. Now that can also happen with SIBO because it feeds off of those. So again, testing is super, super important. I don't like to treat empirically because I don't have to, because that's just, it's not due diligence in my mind. There's just no reason for it. So don't test. Yes, amylase, lipase is not enough. And I threw this in here just in case any of you are like, oh, maybe that's what I have, is that fecal elastase has to be run. It has to be run. So I had someone come in to me, I think it was earlier this year, it's all kind of a blur at a certain point. He came in to me and he was like, okay, so I have pancreatic insufficiency. My doctor diagnosed me with it and put me on Pepsin, which is the medication for it. It's just a pharmaceutical enzyme formulation, and he didn't have insurance. It was $200. So his doctor sent him on his way with samples, because, you know, samples. And then he was stuck. He was like, I lost a bunch of weight. I felt terrible. I feel better. What do I do now? I don't have $200 a month, to spend on this pharmaceutical, so this medication. I'm like, first of all, I have way better enzymes. But second of all, let's start with retesting, because amylase and lipase, first of all, he wasn't low on both of them. He was only low on one, and he wasn't like super low. And so we reran them, and then I added in that fecal elastase, and I actually added in a chemotrypsin as well, and then did all of the other testing like B12 and whatnot on him. And we found out all of his labs came back normal, and this was after he had run out, and we had gotten him on some samples, I had them too, of digestive enzymes that were just a nutraceutical. So, and then we were able to get him on a nutraceutical because he felt so good on it that he just stayed on digestive enzymes that cost him $30 versus $200, and they were better. And he doesn't need to take them, but he uses them when he has some of those heavier meals or fattier meals. So that's that. All right, so we made it through talking about the mouth, talking about the esophagus a little bit, the nose, the stomach, the gallbladder, the pancreas. So again, top to bottom, inside out. It's just a really easy way to do it to make sure we don't miss anything. And I do this in clinical practice all the time. I teach medical students. I have for the last 13 years. And I always teach them to be very, always be methodical about things and go in an order, or you're going to miss something. So now we're at the large intestine, which small intestine dumps into the large intestine. Again, there's that valve in between, the ileocecal valve, and then it goes up through the large intestine, across, down. Now, large intestine, you could still have diarrhea, constipation, you could still have bloating, right? And if it's all inflamed, it's just going to feel inflamed, like it's really pissed off, that's it. You can have your hemorrhoids, you can have fissures in there, you can have all sorts of things as a piece of that. And the reality is if the large intestine backs up, you're going to end up with small intestine symptoms, and you're going to end up with small intestine issues. Now again, there's a test for that, so stop guessing. It's like, I just want to shake some doctors that are like, no, we just gave him rifaximin. I'm like, what? Stop it. Stop doing that. So I use, there are a lot of testing companies out there. I use doctor's data. I've used the other ones where they've looked at DNA. I don't like them as much. I've gone back to doctor's data. It's 3 stool samples. You send it off, and they look for, you can't really see all that well, but dysbiotic flora over here. They don't belong in your gut. Beneficial bacteria over there, because I don't like to guess on a probiotic. I would prefer to put somebody on the correct probiotic for them. So again, why guess? And then these are imbalanced flora. They hang out in the gut. They're not necessarily an issue unless there's a lot of them or there's several strains. So I just had somebody who had 7 different types, and they're all at +3, so they weren't enough to go over into the pathogenic. And I'm like, this is a problem. I'll see a lot of strep in people, especially when they've had their tonsils out, right? Because it doesn't magically go away. What did you think happened when you took your tonsils out? You swallow it, and then sometimes it takes up residence in the gut. It's just logic bombs. Yeast, so they look under a microscope at yeast with this company, and that's great, because then it looks like yeast. But what I'm really interested in is they put them on culture dishes, right? They're going to grow out all these bacteria on culture dishes, good old microbiology. And when they do that, sometimes they can figure out what kind of yeast it is, and that's super important to me. So people often say, I think I have candida, or everybody has candida, and I'm like, that's not true, but a lot of people do have candida. It's not an issue for a lot of people if it's a candida albicans. I'm going to be real honest, we just got that from breastfeeding and birth and being up against our moms, and it was okay with a little bit. Now, some people have large amounts and it overgrows. Sometimes it overgrows in the small intestine as well as the large intestine, and we can still see some of that in stool testing. That's not going to come out in the breath test for the upper GI. But it's important because sometimes it's not candida, and I'm not going to pretend let's just treat candida. That's, no. So this is one of the examples. Sometimes it could be geotrichum or rhodotorula, which are similar, but a lot more, create a lot more issues. So they're a lot more pathogenic, and they create a lot more issues, especially if they get into the bloodstream. Think about that. So that's what I'm thinking about when I see Klebsiella in the stool. Is okay, that's fine until it becomes sepsis for somebody. We're going to treat that. This particular patient had Saccharomyces. This is a little pet peeve of mine. This is a new thing where people will go to the Whole Foods or something like that, and somebody hands them, they're like, oh, you're on antibiotics, you should totally take Saccharomyces because it's fantastic. I just had somebody yesterday, he was really frustrated with his, was that yesterday or the day before? I don't even know. But he was really frustrated with his primary care because he was talking about a probiotic, and his primary care was like, you don't need that probiotic. And Candida is not an issue. Now, he actually had Geotrichum and Rhodotorula, so he didn't have Candida at all. He had 2 different strains that are super important and create a lot of issues. But he was like, well, the probiotic that I give to patients, DO, and he uses a lot of natural medicines, he gives his patients a probiotic. He said, the probiotic I have in it has yeast in it. And the patient's like, what? What is this? And I said, he's probably talking about Saccharomyces. Saccharomyces will compete out abnormal bacteria, and it does withstand antibiotics very well, so people will give them simultaneously. Here's the little issue with that, is that, like other things, it can overgrow. And when it overgrows, part of its metabolism people can actually have something called autobrewery syndrome. So I've had 2 patients with this. And then there was like a famous Texas article that was splattered all over this guy who was drunk from his gut bacteria. That was Saccharomyces. He was drunk off of his Saccharomyces because it's called autobrewery syndrome. So I have had 2 of those patients. I do not recommend Saccharomyces, and if I do, it's short term. All right, so is it Candida? You can see over here, I pulled out the Saccharomyces already. And the other thing that we couldn't really build in here was the fungal stuff. So some of the fungal stuff I touched on. Again, this is a kingdom, fungi, not just a joke. And pun intended. Yeah, my husband thinks I'm funny too. He really doesn't. But the people who have been infected with mold, I want to touch on this because this is super important, and it really is its own little ballywhack. Mold is awful, and mold does the same thing. So its little spores make it into your nose, and it can actually go down into your intestines, and people will have all sorts of symptoms, and a lot of them very random symptoms like pain and fatigue, and those fibromyalgias, those chronic fatigues. IBS is one of those. And so again, as I start to explore things and tease them apart, of course I'm looking at the gut, and I like to look directly at the gut and be like, is it an organism right there? And that would be super easy. Or like a food sensitivity, or is it a combination of those? For some people, it is actually mold. So we're probably going to do something on mold later as its own little entity. Lyme is similar. So a lot of my Lyme patients also have SIBO, and again, a lot of people with chronic complex disease have multiple things going on. But Lyme can also have, along with other pieces of it, can have IBS symptoms. So again, we're probably going to do separate ones on mold and Lyme so that we do them some justice.
All right, so celiac disease. This is my world. My daughter has celiac disease, and that was my first introduction to complex, holistic medicine, complex disease. It is often undiagnosed, especially in children and teens, but it can go undiagnosed until people are in their 50s because it can attack different organs. Only about 30% experience GI symptoms. Okay. Because it's become so popular, a lot of practitioners consider it a fad, so it's often dismissed, and they won't test for it because you don't have classic symptoms. If a lot of them will push a blood test because it is the most accurate. It is often not covered by insurance, and it's very expensive, but there are other tests that we can do for it. But if you go to a mainstream GI doctor, the test was, I think they quoted me $1,100. So yeah, and we have much more affordable tests in the office. It can take years for the damage to become visible enough, and I actually forgot to ask you what type of scopy it is.
Oh, it is an endoscopy.
Okay, it's endoscopy. Okay, so it can take literally years. Like I have people who, they had multiple endoscopies and they finally tested positive for celiac disease when they were 48. Okay, and then in children, sometimes they don't test positive until they're 14 or 15, but they've had health issues, and especially stomach issues for a while. My daughter she puked more in her first 3 months of life than my son did in all 4 of his by that time. It is an autoimmune disease, so treating it is going to require a gluten-free diet, and often that can alleviate symptoms, but usually removing gluten is not the end-all be-all for healing celiac disease. So we definitely wanted to throw that in there because it can be a root cause and it can be ignored. Your endoscopy can be normal for years before it finally gets positive. So we do have other testing.
So biopsy has been the gold standard. I just want to be really clear about that. They have to test 3 sites. So when I did my GI rotation during residency, I rotated with one older GI that had, he always did 1 site, which I knew was not accurate. And then I did someone who was a little bit more up on advances, and he did 3 sites. He was really clear about that. So you really should have 3 separate sites of a biopsy. But here's the thing, sometimes it's not wherever they decide to biopsy. Now, ultimately, we're hoping that they can see these little villi come out and they'll start to actually retract with celiac because it's autoimmune, it attacks it, those villi where you had that absorption. And so they should test where they see blunting. It's not quite that easy when you're looking in a scope. They're really just randomly choosing sites most of the time. And sometimes they'll do more sites. So that's why it's super important for the blood testing component as well. Other pieces about that, so there's non-celiac gluten sensitivity, which she's going to talk about a little bit later. This is super important. Now, for 2 reasons. One, I need people to stop saying they have celiac when they don't have celiac, because then people are being discounted when they do have celiac, and it becomes a huge problem. Like I just had a family where one of the kids has celiac, and she needed a medication. And so I'm on the phone with the pharmacist, and I'm like, I need to make sure that this is a gluten-free medication for this patient. And he's like, what are you talking about? Like, he didn't really think anybody had celiac. And I'm like, no, this is huge. Because one celiac might have really bad GI upset, or might have like off-the-wall outbursts in these kiddos, or, you know.
My daughter gets headaches now. She graduated from GI issues to headaches, and like her body hurts.
And other people will end up in the hospital. So this is important. Now for our non-celiac gluten sensitivity, I think it's just been so frustrating for them to not realize, like not be able to get that diagnosis, and they know they eat it and they know they get sick, but they don't have celiac. We use a wheat zoomer in our office, so we're actually looking at actin, and we're looking at zonulin and the proteins and all of those pieces, so we can see, is it just leaky gut, or is it a celiac gluten sensitivity? And then we treat it as such. It doesn't mean that they're not going to avoid it, but just use the correct terminology. So it's a little pet peeve of mine for the people that really need that care, that really need those medications, that really need a full-on gluten-free diet, because it could kill them, versus like, I'm going to feel like crap. Like me, personally, I have non-celiac gluten sensitivity. I'm an MTHFR defect that predisposes me towards it. So that's different.
Okay. Our favorite topic.
Antibiotic overprescribing. We talk about this all the time. It's so interesting. I'm not going to refer a whole lot to COVID, because that's, again, a whole fun, charged topic of many things that we need to discuss later. But one of the things that was coming up is immunologists, and I was reading some articles of epidemiologists. I'm always looking at people that are smarter than me, because thank God there are those people, so I don't pretend to be an immunologist by any means, or any of those. And they were talking about antibiotic overprescribing and what that would mean, the concerns around it. And this comes up for me really with everything, is, you know, here, most of my patients that have gone to the hospital recently with COVID have come back with 2 antibiotics and Pedialyte. Or just Pedialyte, but that's a whole other topic. But the 2 antibiotics, their concern was that they were going to have a co-infection of the virus and multiple bacteria, and that's something that we're looking forward to the winter when, you know, when those bacteria, that's their season, right? Or bacteria and viruses, like we switch these seasons on and off, and we'll have both kind of in the transition, is what I meant to say. So antibiotic overprescribing, one, it messes up your gut. We know that's super important for our immune system, right? There's an entire section of science and scientists called enteroimmunologists, right? And there's some subsets of that as well. I love enteroimmunology, it's really important. but your immune system starts in your gut. Antibiotics, we need them to work. And so we need them to work for the infections that we need them to work for. Because I have seen those patients that had post-streptococcal meningitis that should have had antibiotics, and it ended up, I had a little girl that was a vegetable once that didn't get the antibiotics she needed. So appropriately placed antibiotics, this is like a broken record, but I like to talk about it each time. Appropriately placed antibiotics are so super important, and we need them to work for the infections that we need them to work for. The problem is when they're prescribed for colds and when they're prescribed for flus and they're prescribed for these viruses and they're prescribed for sinus infections that weren't actually bacterial, and all of these pieces, these ear infections that aren't necessary, where they're not actually following standard of care, we're going into antibiotic overuse. You're not going to have that sensitivity to those antibiotics when you do need them. And then we're trashing our own innate immune system with making our intestines inflamed, getting rid of our beneficial bacteria that would be there in order to fight off, the bad buggies, in essence, and the bad viruses. Because we live with a lot of viruses in our gut that people don't even know about, that are actually serving some kind of function for us as well, or not necessarily hurting us. Okay.
There we go.
All right.
You want to give us 1 second?
1 sec. We're having some Instagram.
Timed out.
Our Instagram timed out, so we're getting that going again. Right as I got on my antibiotic soapbox.
Wow.
Like my celiac soapbox, where I'm like, please, we need antibiotics and we need them to be effective. So sorry, Instagram.
You missed the whole section on antibiotics, so please make sure you watch this link on YouTube to catch that part, because you do not want to miss it. All right.
Okay.
Ooh, where's the clicker? Did I get it?
Okay, got it. So scar tissue. This is kind of an outlier, but it is really important for people. So I've seen people that had procedures. I always ask them, like, maybe it was a C-section, maybe it was gallbladder surgery, maybe they had, something, whatever it may have been. I'll see this sometimes, rarely, but sometimes after really extensive laparoscopic surgeries for one reason or another, and their endometrius, whatnot. Where they'll just have scar tissue buildup, and this is a great picture to show what those adhesions look like. And it can actually pull your intestines, right? So it can pull your intestines in this direction or that direction. We have the ability, so for any woman who's ever been pregnant or seen a pregnant woman, like, we stretch pretty dang well, and we can move pretty well, but at a certain point, these can actually be detrimental. So if it's pulling it, it's restricting it, any of those types of things, or like I said, I had that patient with endometrial tissue that was actually strangulating her bowel, and she lost a good portion of her bowel to it. Oh my goodness. I don't even know where to go with the Band-Aid approach, but I'm really, really tired of it, because I'm tired of seeing people not treated well for things that really should be treated well. So the Band-Aid approach is you have reflux, I'm putting you on an antacid or a proton pump inhibitor. There you go, bye. That's our conventional counterparts. Now, I'm seeing a lot of Band-Aid approaches from my colleagues in the integrative world, in the functional medicine world, and in the naturopathic world, and it really frustrates me as well. So just because you're going to see one of these docs does not mean that you're completely, out of the woods for Band-Aids, because sometimes we really do. I'll be really honest with the patient. I'm like, you need a Band-Aid right now, and I'm giving you a Band-Aid. That's it. And again, appropriately placed interventions are super important. So I'm one of those people that believes that all of the best of our medicine should be used simultaneously and individualized for patients, and that's where we really come together in our practice. So Band-Aid approaches, I have seen a lot of this lately with IBS, and a lot of it, unfortunately, where people are coming in, they're like, I've seen 6 naturopaths before you, or I've seen a functional medicine doc and this person and that person. I'm like, oh my gosh. So they gave you bentonite clay, they gave you a GI detox, they gave you some probiotics.
The liver flush?
If I see one more gallbladder flush, I'm going to freak out.
Yeah, gallbladder flush.
Sorry.
Thank you.
I'm not saying appropriately placed. These things can be incredibly important, but oftentimes they're being used as Band-Aids. So if you're getting any of these treatments and there hasn't been testing, that's probably a Band-Aid. Or we're hoping it works. Not we, because I wouldn't do that. Or I try not to do that. Happens sometimes. So those are the Band-Aid approaches to that piece.
My other favorite one is go on FODMAPs. Just do FODMAPs for the rest of your life. And I'm like, no, that's not going to work. We're going to talk about diets here soon. So Band-Aid approach can be medicine. It can be, I had a person who, she went to the hospital. They did every test. She got a food sensitivity panel. Nothing popped. And so it was basically boiled chicken and white rice and bananas, and then she was still vomiting every night. And it's been slowly and surely getting better, but they basically were just like, they threw up their hands. And so she's just her Band-Aid was just eating nothing, So there's a lot of different types of Band-Aid approaches out there.
Go on the brat diet. That's your solution, is the brat diet.
The brat diet.
What? That's not a solution. Let's figure out what's causing this.
All right, so we've talked about this a lot, but our approach to diagnosis and testing, we are thorough. We are going to pull things apart, and we're going to run the tests that need to be ran, and we're going to do it as much through insurance as possible if you have it, and when it's not covered or you don't have insurance, we're going to find you the most affordable labs that do quality work that we can.
We've had a lot of doctors attending these recently, which I find really interesting, and I appreciate it. We're going to do some practitioner courses as well here soon. So
2021.
So that we can train doctors in some of those more niche areas like SIBO, where it really, like, you have to.
You have to know what you're doing, and you have to know what the options are. A lot of times you don't even know.
Clinical experience goes a long way in pieces like that. But what I would say is, I tier things out with testing. This is important, is I tier them to, this is what your insurance covers. If you have a high deductible, then I would recommend this insurance company, or I would recommend this approach, because I'm always, we're always advocating for our patients here. I did a video on that earlier of, this is what needs to happen, and your doctor should be advocating for you. And maybe your doctor does, and then make sure that they tier that out so that it's achievable for you, because that's also the other thing that I see quite a bit, is plans that aren't achievable, or testing that was achievable, or somebody spent $5,000 on testing or $1,000 on a bunch of functional medicine testing. I'm like, you don't need any of that. So, good, hearty, conventional labs, super important, rounding those out as much as we can through insurance, and then tiering those out for things that, because if you have IBS, I'm worried about nutritional deficiencies. Mm-hmm. Some of that we can get covered, some of it we can't. And then looking at the root cause, tiering those out. So sometimes I want to test the small intestine and the large intestine, but all of your symptoms are really upper GI. And I'm going to say, let's start with upper GI. Let's do SIBO and look at this piece and do the H. pylori. And then I'd like to do the stool test next and look at the lower GI. Or, really, I'll be honest about things. And your doctor should do that too, to stratify them out. So this is where you can advocate for yourself, is make sure you're making your own timeline. You're using a top-to-bottom approach, so really kind of you can start to isolate what your symptoms are, and what they might be, what exposures you've had, so you can bring those to your doctor and then just say, I'd like to start here. This may not be where you want me to start, and hopefully they have a really thoughtful approach to that, of saying, I don't think, sometimes I'll just tell patients, okay, well, I wouldn't recommend that, but if you want to start there, we can start there, or okay, let's do that, but I'd also recommend this, because if we don't get rid of this, you're going to have this forever.
All right, and we also incorporate lifestyle. This is my favorite part, because this is where you are in control, and you have a lot of say in your quality of life through this process as we're untangling the web of what is going on behind your IBS. There's a lot that you can do in the meantime that can alleviate your pain and discomfort. All right, so number one is drink water. I can't tell you how many people don't like water. They drink artificially sweetened or artificially colored things with or without caffeine. And lack of water causes a lot of issues, and it can actually help alleviate a lot of issues just by being hydrated. Also helps keep things moving. So if you're dealing with constipation, making sure you're getting adequate water intake it's going to help.
A little tidbit on those flavored waters and those flavored drinks is a lot of people, they're like, well, I drink the ones with, whatever the sugar alcohol is, plug in whatever your favorite sugar alcohol is. And I'm like, great, that's hyperosmotic. So what that means is that molecule is going to pull water towards it, and it's going to cause diarrhea. So sometimes IBS is actually caused by some of those sweeteners. Keep that in mind, because I would love for that to be your slam dunk if that's the case.
Yeah.
And then we also did a newsletter on stevia pretty recently, which I do like a lot more than other docs. But if you have a ragweed allergy, I just had somebody today who I was like, oh, you're allergic to ragweed, don't do stevia. And it was a pretty significant allergy where I'm like, okay. So that is going to cause some pretty good upset for them.
Yeah. And artificial sweeteners, including some of the natural ones, can cause a lot of sinus issues and headaches and things like that. So just switching out your drinks to plain water is going to be huge. And I understand that sometimes it just doesn't taste good. There's ways around that.
Add lemon.
Lemon, strawberries. I love doing strawberries with lemons. I love doing blackberries with sage and like crush them, kind of like a mojito without the alcohol.
Yeah, I'm not the Pinterest person, so lemon it is.
I just smash it with a spoon and add water. All right, so there are IBS diets. Okay, the most popular one right now is FODMAPs, and I can never say what they stand for, but it's types of sugars and fibers in food. Okay. FODMAPs has its place. It is a great short-term diagnostic tool. It is. It eliminates a lot, and it alleviates symptoms, so then you can start pinpointing what foods are causing you issues. And this is great for also helping to just reduce inflammation, but this is what I would call a Band-Aid approach. It is a diagnostic tool. It has its place, but I think it's overused. It is effective at alleviating IBS symptoms, but you can't maintain it forever. You can't eat one spear of asparagus and a quarter of an avocado and so on and so on. It is difficult to follow. It eliminates a ton of good for you, nutrient-rich foods. The rules are very vague. Every single website says something different. Literally, I looked at like 40, and everybody had something different. And it doesn't address the root cause. So if you're in a lot of pain and you're waiting for your test results and your doctor's like, do FODMAPs, it is a great tool, but just understand that it is not a lifelong diet or protocol you'll be able to follow. And then we have the specific carbohydrate diet. We like this one a lot for GI issues. It is effective for helping to resolve IBS. It's much easier to follow, and you're going to be on it for 3 to 6 months. Again, this is a short-term therapeutic protocol. A lot of the diet focuses on healing the gut, and depending on the root cause, can help resolve it or at least heal the damage that was done after you've gotten it taken care of through medication and all of that. And then we graduate up to just the anti-inflammatory diet, right? So if you've resolved everything, you've healed your gut, this is probably the one that you'll probably stay on long term. It removes a lot of non-inflammatory foods. We encourage you to stick to following your food sensitivity panel and not reintroducing those foods unless it's guided. It focuses on minimally processed foods. It is definitely the easiest to follow. You can go to restaurants, you can live your life, you can travel. It's a lot easier to follow. Depending on what's going on and how inflamed your intestines are, it might still be too fibrous to just go here and not go to another one. But I think it's important to know your options and their uses. All of them are useful, and it just kind of depends on what stage you are at. All right, so we talked about celiac disease, and we talked a little bit about non-celiac gluten sensitivity. If you just have generic IBS, right? And a lot of doctors, it's coming around, it's gone mainstream, they'll just say remove gluten. Well, why do they want you to remove it? No matter what, whether you are sensitive to it or you have an autoimmune reaction to it, it is still a highly inflammatory food that we eat way too much of. It is in everything. It's in salad dressings, it's in cheeses, it's in lunch meats, it's in
our body products.
It's in everything. It's in sweeteners that you add to your coffee. It's in everything. So we're highly exposed to it. It's a highly inflammatory food that we eat too much of. So if you remove it and you feel better, but your panel says that you can handle gluten, then it was just that it was just too inflammatory, and you needed to give your body a break so it could heal. Okay.
Some people feel worse before they feel better. I always like to tell people that because they'll say, I took it out for a week and I felt terrible, so I put it back in, or 2 weeks, and I'm like, okay. When I take things out, I eliminate and challenge them, which I do a lot with my food sensitivity patients, because I'm not putting on anybody saying you can never eat any of these foods ever again. It's all about a tiered approach in my mind. And so keep that in mind, is that gluten, dairy is the same thing, where they have these opiate peptides in them that bind to your opiate receptors in your brain and give you high. That's why we crave them, so that's why we crave breads, and that's why we crave dairy. For dairy, a baby needs to be addicted to its mother's milk, which we've talked about in a bunch of other talks. Now, for gluten, it's a little bit different, but as we talk about those casomorphines and gluteomorphins, keep that in mind, that some people feel worse when they take them out electively with non-celiac, just to see. You might feel worse before you feel better, and then start to feel better after, so give it enough time.
Yes. So that goes into the temporary removal versus permanent. We do recommend testing. It's important not to guess. And I know I've had plenty of people who just remove it for 6 to 8 months until their IBS resolves, and then they can eat it in small amounts, like once or twice a week, or if they go on vacation, it doesn't bother them. But if they start eating it daily, they start having issues again. But their panel came up. So it's just listening to your body. But is it necessary? I would say that if you're highly inflamed, it's not going to hurt. So short chain fatty acids. They come from fiber. We are, as a nation, we are very fiber deficient, and that has widespread consequences, including our digestion and IBS. A lot of people suffer from IBS, or just discomfort. Maybe, hopefully, it doesn't progress into something as painful as IBS, but. So by eating fiber-rich foods, and I'm not talking about taking chicory root powder in your smoothie, okay? But actual fiber in your foods, it supports a healthy colon. You know about this, they talk about it all the time. That's why there's fiber supplements everywhere, bran flakes, all that stuff, right? But they also reduce inflammation. So again, you're inflamed, you got stuff going on, so that's going to help. And then it helps regulate bowel movements. Again, that's why fiber supplements are so popular, and this is why the fiber supplements fall short. You really need to get them from food, but they play an essential role in digestion and digestive health.
There's a big difference between types of fibers too. That's super important. So I'll have a lot of people saying, "Oh, I've tried fiber. It made me so sick," or "I tried this or that or the other thing." And the reality is the type of fiber makes a difference. And then some people are sensitive to specific things, like they may be sensitive to flax. My patient earlier I want to do seed cycling with, and I can't do the flax component because I came up on her food sensitivity panel. There are soluble and insoluble fibers, so that's a piece of it. I really like them to be a mixture of soluble and insoluble fibers, versus the insoluble that obviously, so insoluble means it doesn't come apart when you add water. Those are the really bulky ones, like your psylliums and things like that, and that can be constipating to people if they don't have enough water. Some people say, okay, well, that encourages them to drink water. I like them both. When you have flax, if you've ever ground it and put it in water, it becomes a demulcent, so it becomes like a gel.
I use it as an egg replacer.
Yeah, so it becomes a gel, and that means that it has both of those components, so that can be really helpful too.
All right, so exercise actually does help with IBS. It is an important component. If you struggle with staying regular, it keeps you regular. I have a friend who is a marathon runner, and every day she has to plan a bathroom stop about 1.5 miles into her 10-mile run, because it just gets things moving so much for her. And so when she's not training, she actually finds that things change. And so she tries to stay consistent in her activity and change it up versus stopping, because when she stops, she actually has issues. It promotes a healthy microbiome. It actually does change your flora, and it changes it for the better. So incorporating movement into your day is important on so many levels, but if you're specifically dealing with IBS, you do want to make sure that you get a good amount of exercise and 30 minutes a day of like walking and doing things. I prefer to be more intentional where it's more exercise, but just getting moving is really important. And it also relieves stress, and we know that stress does affect our stomach. We think about as something that makes us nervous, like going up on the stage and presenting, and our stomach starts cramping, you know, or we feel nauseous. So we know that obviously mental stress can cause physical symptoms. So exercise can help alleviate that and help your treatments work more effectively. And so that leads us to stress management. Got our yoga pose here, right? So a few strategies that can help in the moment, like if you notice, so I have a friend who her GI issues flare every time she starts getting stressed, and it's like debilitating, but she has something big coming up. And so finding ways to manage stress so it doesn't get to that point to aggravate your symptoms, especially if you've gotten them under control, are things like box breathing, where you breathe in for 4, you hold it for 4, you breathe out for 4, you hold it for 4. You do that 4 times. Very effective, very quick strategy. It's one of my favorites. A regular yoga practice, mindfulness exercises to help getting you in the moment versus thinking about ahead of what could happen. Perspective change and then journaling are all extremely effective ways to manage stress.
Mm-hmm. And we covered a lot of this in our when we did our holiday back in December.
Mm-hmm.
Healthy through the holidays. We covered a lot of those pieces in more depth. Talking about your immune system very specifically. So I think a lot of times my patients will be like, yeah, okay, that's stress benefit. I know, I need more sleep. Yeah, I know I need to drink more water. Like, yeah, I know. You know, but it doesn't feel real. The effects don't feel real until I'm like, all right, so we're going to go in. Sometimes I'll do this. I'll just go into PubMed, and and that's our big database of research, and I'll pop something into PubMed, and I'll be like, there are 400 studies on this, or there are 1,000 studies on this, or whatever it may be. Like, this is very real. Let's pop into one specific study, you know, and I'll look at it, and we'll go through it, and they're like, oh, you know, because I think a lot of times those lifestyle stuff are like, I know I should. But am I going to?
I'm busy. I don't have time. Life is crazy. Life is crazy for everybody, and little short strategies can go a really long way. It does not have to be overwhelming, which is why I try to give you the simplest ones, because they're effective and they work. And again, like if you have your IBS under control, but you notice that it comes in flares and they're stress related, this is something you can do to mitigate that very quickly and effectively. So supplements, supplements have their place. They're extremely helpful. We have 3 of our favorites that we find to be pretty effective for a lot of GI issues. We have L-glutamine, specific probiotics. Again, that's where the testing comes in to make sure you're taking the right one for what's going on in there, and then enzymes. So we've talked about these 2. We have not talked about glutamine. Would you like to talk about it a bit?
So glutamine is fuel for your intestinal cells. They need glutamine in order to turn over in a healthy way. So in my most basic level, people tolerate it well. I always do it gluten-free, just for a cleaner formula. In case somebody has a non-gluten sensitivity, we'll say certified gluten-free on it, which I have a post on Instagram of what you should look for glutamine, and I'm up in like the 3 to 5 gram range for this, and this helps most people. Now, one nuance of this is children, we have to watch glutamine because it can be neuroexcitatory in young children, so there are some cases of like where we're seeing kids who are super sick, in 1 and 2 years old, 3 years old, where they've had seizures because it's neuroexcitatory. But in adults or in a child that is a little bit older, I'm giving it above usually 4 to 5 years old in smaller doses that are Asian weight appropriate. Very, very, very helpful. Nice little side effect is that it helps you build lean muscle mass. That's why it's in all the bodybuilding formulas, and I'm a big fan of that. The other one we talk about, which we didn't put on here, is GI Revive. And the reason we didn't is because glutamine's in GI Revive, but there are some herbs in there that people either do well or don't do well with. And for our SIBO patients, they can't handle GI Revive. because it has things like marshmallow in it, but it does also have other components that are necessary, like zinc carnosine and N-acetylglucosamine, which is not the same as N-acetylcysteine, very important. But those formulas can be really helpful. Basic glutamine goes a really long way. You can get them inexpensively, and you can go pretty high in your dose, and you're not worried about side effects of it. It will only help, again, when we're talking 5 years and older. And if it's a kid, I'm always, anything like that is still dosed by weight, and dose, it's really weight that we're not using age for that, because weight can vary quite a bit.
Yes, it can.
Probiotics, the other piece about probiotics is that if I don't know any better, like if I don't know what's going on with the patient, I'm avoiding all probiotics with FOS in it, with this fructooligosaccharides, because it's going to feed bacteria, but it's also going to feed bad bacteria as well. So people will be like, I take a probiotic, but I get bloated every time, or I feel sick every time. And I'm like, does your probiotic have FOS? It's totally possible. And a lot of the really good formulas that I love still have FOS in them, and they have their place. But I'm usually going to avoid FOS in my probiotics to begin with until we know better. And then the other piece is there are probiotics made for SIBO. And so if I'm really worried, because my SIBO patients are really sick, and so that's why I keep kind of coming back to that. And they're the harder patients to treat versus the large intestine, which is much easier to be methodical about. And for them, I'm using Lactoprime Plus SCD, so it's literally has SCD in the title, which is how most people know. And often they're doing really well on those.
All right, and then of course, we've talked about this. Depending on what your root cause of your IBS is, there might be other things that you need to take to help alleviate that, so you can have normal digestion again. And then there are manual therapies, and a lot of people talk about them and talk them up a lot. So we have things like going to the chiropractor and getting an adjustment, and that can really alleviate a lot of issues, especially chronic constipation. Or if somebody has urinary problems, like an adjustment can do wonders. Massage can help get things moving. Acupuncture, and then our favorite at-home modality, our castor oil packs. They're great for so many things, but they do help with digestion and IBS and inflammation, and it's just they're like magic.
So chiropractic adjustments, a couple things I wanted to touch on with that. One, where do you think the nerves that innervate your gut come from? Like, just real basic here. So it's super important to have good alignment. What they can do also, I love my friends that are fantastic chiropractors, and I refer quite a bit, are those maneuvers. And so I'll have patients who are like, oh, I was trying to do the iliocecal maneuver on myself. That oftentimes I'll do it with IBS or SIBO, because that's the junction, right? That's that valve right between the small intestine and the large intestine, and it's really hard to do on yourself. And so I'll refer over to a chiropractor for that, that is specifically trained in that, to do those. And also, similarly, things like there's a hiatal hernia maneuver where they can actually pull down when you have your stomach actually goes through that opening, and you get something called a hiatal hernia, and they can actually adjust that down. You can do it yourself, you can pull, but I'm going to tell you it's not quite as effective. So that's really, there's so many things, appropriate adjustments by a well-trained chiropractor are night and day for a lot of people. So those manual therapies are super, super, super important. Similarly with massage, I send directly to people that do like different massages. So abdominal massage is not something that everyone does, and that's what I'm talking about, is abdominal massage. Sometimes they're nuanced, and we need that massage therapist who works specifically with trauma release, or that adhesion, the scar releases, or any number of things. And so having somebody who knows how to do that, super important.
Yeah, and not every massage therapist does. You can't go to Massage Envy.
No.
And just request it. Like, you need someone who's specially trained. There are like certificate courses and things like that where they can learn specifically those modalities. So just be sure to vet your therapist before you schedule an appointment. I mean, massage is great no matter what, but if you're looking for something specific, you want to make sure that they're trained in that specific modality.
Always ask them, because just like anything else, you can watch a YouTube video on it, or you can have experience in it. And so I always send, my patients to the most experience that I can, or that I know of. Castor oil packs, the one thing I want to mention about that, so you can Google how to do those. I do these a lot with my patients for all sorts of things. You can do them for sports injuries. You can do them, they just bring down inflammation, ovarian cysts, endometriosis, all sorts of things. I did it recently with mastitis. So you can do it for inflammation. Do not consume, disclaimer, do not consume the castor oil internally, because sometimes people will be like, oh, I remember my mom made me do that when I was constipated as a kid, or my grandma, or whatever, and I'm like, please don't do that. That's not what I'm talking about here. It's castor oil on the area with a non-absorbent cloth over it, and then a heat source that will warm it up and help with absorption.
Yep. All right, then we have enemas and colon hydrotherapy. I actually don't know much about this. I don't have much experience in it, so I'm going to pass the baton back.
So constipation is really undervalued as a symptom. It's super important. I know what it feels like, and many of you probably know what it feels like, where it's like, oh my gosh, I can't, like my husband says, I don't even know how people don't go every day, and like I would feel like I was going to die, and I'm like, oh, so traumatic. But it's pretty intense. What people don't necessarily think about with constipation is not just that it's backing up from your large intestine into your small intestine and cross-contaminating bacteria that don't belong in that section at a certain point, because pressure is going to pressure, right? Like it's going to backflow. That's what happens. The other piece is that when we run through our detox pathway, so we did a talk on detox, and we actually went through phase 1, phase 2, phase 3. We talked about every single nuance of this, and that's also on YouTube. We also talked about the gimmicks of detox, because, of course, there's the myths and the foot baths and the wraps and the whatnot, and we debunked a lot of those, which made a lot of people upset. But I don't care, because I believe in science is really important. So a big piece that we covered in there with the constipation is that you make things more toxic and get them out of your body, right? Like part of that detoxification process in the phases is it becomes more toxic. The other piece is as stool sits in your bowel, so if there are any women in here, this is super important. This does happen with men, but with women, I see a lot of estrogen dominance. They're constipated quite often, and your estrogens actually reabsorb. And so it'll reabsorb and reabsorb and reabsorb. This is super important for, those patients with estrogen dominance. So you've got to get all the toxins out of the body, and not all the treatments work. Like sometimes fibers don't work. I have patients with gastroparesis. They're just not even moving at all, especially after so many years of the intestines being damaged, the nerves being damaged, because they were diagnosed with IBS, I say that like I'm not making fun of it. I'm just saying that people didn't dig for them and actually get them any answers, and so they walked around with this like IBS diagnosis and didn't have any answers. So the constipation piece, they can actually have some nerve damage over time, and some of them had eating disorders that led to the gastroparesis and the nerves dying. But you have to get it out of the body, and sometimes that means we have to manually get that out of the body. Everybody recognizes that. They do enemas in hospitals. We do enemas when they are required. Sometimes people are able to take fibers in, but if your intestines are not moving around, not moving along properly, they don't have peristalsis, so they're not moving, you don't have the nerve innervation to help them move, or any number of reasons, then you just got to get them out. And that's where enemas and colon hydrotherapy come in. Most people think enemas and they think of like little fleet bottles. Don't love them. Don't love a good fleet bottle. That's totally different. I often give my patients the enemas you can get online, where it's a hot water bottle and you can fill it up with, warm your water up so it's the right temperature, and actually slowly infuse it into the colon, massage it around, and get it out. Sometimes people are using things like coffee enemas, and I don't talk a whole lot about those. Those are really complex because you're absorbing a certain amount of that. And organic versus non-organic coffee, that's a whole other thing. So I think we covered that in the detox talk too. And then there is colon hydrotherapy, which is totally different. Somebody actually like, a person who's been trained in this, I hope, is going to help facilitate this with a machine where they infuse water with the machine up through your large intestine. And then they're going to let it drain out and infuse it again and let it drain out. Sometimes they'll do massage along with it. Sometimes they'll do castor oil with it. There are closed and open machines that get a little bit more complicated. I am not a fan of the machines where there are practitioners, there are machines where they leave you alone and they say, okay, so what you're going to do is you're just going to, mosey on down. And I'm like, I don't know about this. Like, I'm that person. And then you're going to wait until you can't handle it anymore, and then you're going to pull up and let it release. My worry about that is that if you don't have somebody who's properly trained, you can actually hurt yourself in the long run. It can cause a lot of issues if you're allowing overfilling, if the machine, something happens with the machine component. There are lots of pieces of that. I've also seen people who did colonics too often and caused SIBO because it pushed their bacteria up into their small intestine. And then really well-trained practitioners can actually push probiotics at the end. So there's a lot that can be done with colon hydrotherapy, and there's a lot that you can do at home just with enemas, but ultimately I want somebody pooping every single day, getting the toxins out of their body. And I know that that's an overutilized term, toxin, like everybody's like, get the toxins out. And then there's like all these other people that are like, there are no toxins, that's just made up. And the reality is there are toxins. We go through these phases of detoxification. You're supposed to get them out of your body. You need to poop in order for that to happen. You do reabsorb toxins. You do reabsorb hormones and estrogens as a result of being constipated. So you do have to get that out. And sometimes those are necessary for other things where, again, we can do probiotic pushes and whatnot. So it gets nuanced from there.
Yep. All right. So, woo! Thank you for staying with us. We always go over. We're like, we're going to give ourselves room this time. That was a lot of information. We hope that you found it helpful, that if you have IBS and you're walking around with that diagnosis and you're not getting better, that you know that there's more you can do. That there are practitioners out there who can test you for other things and can help you resolve them so that you can feel normal. You don't have to worry about going to the bathroom. You don't have to worry about struggling to go to the bathroom. You don't have to suffer with systemic problems that stem from IBS. It's amazing how, I have one of my stories where literally we removed gluten and she went from watery diarrhea 12 times before noon in 9 months to being normal, plus off of a bunch of medications. It's sometimes it can be that simple, and sometimes, as you know, it can be way more complex. You have power, and there's a lot that you can do. And again, if you want this PowerPoint, just DM us and let us know. If this is on YouTube, again, just send us a message. Eventually, we're going to have a link that sends it to you automatically. That's in the works. We're getting there. So really exciting, but we hope that you feel empowered. That's our most important thing, and that you feel like you have a place to start. And thank you for joining us.
All right. If you have other topics you want us to cover, let us know, because again,
otherwise we just pull them out of a hat and talk about things that we want to talk about, which is fine. But we want to help you guys more than anything.
Thanks for joining us. Have a good night.
Bye.